Hello and welcome back to the Under Pressure podcast, where we explore the frontiers of trauma care innovation and the very human stories that connect them. I'm Dr. Jonathan Sackier and I'm proud to be your host. Before introducing today's guest, it's important to specify that this podcast has been supported by My01, a Canadian medical device manufacturer. So please refer to the show notes for further information, and you can be in touch with us at underpressure@nextsense.com. That's underpressure@nxtsens.com to ask any questions that we'll endeavor to answer, or also to suggest a topic or a speaker for a future podcast. Today, I have the pleasure of welcoming Mr. Dafydd or Taff Edwards, a trauma and orthopaedic surgeon whose experience bridges military medicine, major trauma centers, and advanced upper limb reconstruction. Taff and I met at a dinner and had a great old chat. I'm fascinated with military medicine, and boy, he educated me a great deal over a very pleasant meal. Mr. Edwards serves as clinical director at one of the UK's busiest trauma centres, St Bartholomew's in London, or BARTS as it's fondly known. It's part of the National Health Service Trust, and he's a consultant trauma and orthopaedic surgeon also at the Cleveland Clinic in London. BARTS is, in case you didn't know, the oldest hospital in the world, having been established in 1123. That's just before midday in modern speak. Taff has been deployed as an army surgeon in conflict zones, so he's seen active duty, and he continues to teach and research topics ranging from peripheral nerve injury to polytrauma management. His career offers a rare lens on leadership, innovation, patient care, and people who have literally been under pressure in the clinical environment in both the military and civilian arenas. So without further ado, Mr. Taff Edwards, welcome to the podcast. Thrilled to have you.
Yeah, it's great to be here. Thank you for the introduction.
And I think it's fair to say that you've just finished a busy trauma call. Did anything interesting pass under your scalpel?
Yeah. So a full day in trauma theatre. We tend to keep all the difficult forearm or elbow stuffs for me for my Thursday all day list. Started off with elbow dislocation, all the soft tissue has been ripped off. Then forearm, radius, ulnar, olecranon, coronoid fracture, and then just to finish off a simple ulnar fracture. Great, love it.
So I'm as a good Welshman, I'm guessing that rugby is more your thing than football. Would that be fair? Is that a good guess?
Yeah, absolutely.
Do you watch any footy?
With my brother, we're Cardiff City fans, so we do our best to keep in touch with those. But it's been a difficult few years.
Yes, it has. Yeah, but they've had their highs. But the reason I ask you is the team I support, long-suffering Tottenham Hotspur supporter. A couple of years back, our goalkeeper, Hugo Lloris, who was the French goalkeeper and captain, dislocated his elbow. And God Almighty, I remember seeing it as it happened. It looked horrific. I know nothing about that injury. Can you give us a sort of like an idiot's guide to elbow dislocations?
Yeah, it's right. What's interesting about elbow fracture dislocations, there's a certain pattern which is known as a terrible triad. And the reason for that is because historically, the outcome was almost universally terrible, with a combination of fracture to the radial head or a coronoid and lateral ulnar, medial collateral ligament injuries. You just ended up with this horrible, either stiff elbow or this horribly unstable elbow. And over the years, we've gone back and forth between stability versus stiffness. But actually now we should probably start talking about as the less so terrible triad, because we're just learning more and more of it. And it's something that I've looked into, researched, and I really enjoy doing it. The key, early mobilization, get the elbows going, because they hate being immobilized. Whereas back in the day, into a cast for 4 weeks. So less than terrible triad is what I renamed them.
I'll keep that in mind. He actually made a good recovery, pretty good goalkeeper. So I'm pleased to hear that. So I mentioned in my intro, Taff, that your career has spanned army deployments, pretty austere environments to work in Africa, and now leadership at a major UK trauma center in an urban center. What took you into trauma surgery, and how have those very diverse experiences shaped the way that you approach patient care today?
Yeah, I was actually probably quite late into trauma per se, trauma orthopedics. Certainly at med school, my intention was to become a pediatric endocrinologist.
That's a
Yeah,
bit of a stretch to get from
yeah.
trauma.
I used to have a few great brain cells between me, but my want to be an austere physician has been there for a while. During my gap year I went backpacking in Africa and rather foolishly found myself in Rwanda in '94 during the tail end of the civil
Yeah,
war.
that was a dangerous place to be.
There was a lot going on. It was very unstable, and there was certainly a moment where we all had to evacuate very quickly from Rwanda because they were threatening about shutting the borders. They couldn't guarantee safe passage, so we all got pretty much told to leave as soon as we could. And I remember crossing into the sort of Uganda area, and there was a United Nations field hospital there, and we just camped down there for a couple of days. And I met a German physician there who showed me around the field hospital, and it was at that moment I kind of this is where I want to work.
Right.
Just seeing the setup, the location, the type of work he was doing, that pushed me down the route. So at that stage, I recognised that joining the army at the end of my medical school years was going to give me that calling which I had, which I knew was kind of internal inside me.
Yeah, I've had the pleasure, privilege, honor of operating in some challenging places, such as in India and remote areas of India and China and South America. And I'm always humbled by what I see that, I've been invited to go there and teach one thing, and I come away learning 10 things for the one thing I taught, and also the ability to do a great deal with very little, actually. And I've always found that when one travels, the people that you meet, they tend to be they're made of the right stuff, if you will, to be doing what they're doing. And they're certainly doing it for the right reasons. And I think it imposes a lot of humility on us. Did you have similar experiences, Taff?
So within the field hospital setting, you have to remember that we almost uplift a hospital with UK standards and equipment into the austere or war environment. So the guidelines, the equipment we use, the surgical skills, the techniques, they're all the same as we would use in the UK. In fact, in the field hospital in Afghanistan, we even had a visit by the NHS to have a look at how well our standards were, and we appeared, I think, almost top compared to all NHS hospitals, even though we were in Afghanistan. And that's
Wow.
not a mark. You can look at it both ways, can't you? But that was a mark of how good the standard of care we're able to give.
Yeah.
However, so on the flip side of it, the difference between working in NHS and working in a military field hospital is that as a doctor, you still have to have that direct communication with your commanding officer and leaders, because there is resource limitation. You can't just use all your blood supply in one patient, because then
Right.
you don't know what's around the corner, but there might be another patient waiting next door. So you do have to be more aware of your resources. So it is a resource poorer environment rather than a resource poor environment, which you may have experienced elsewhere around the world.
Yeah. I certainly saw with I spent some time with the Australian Royal Flying Doctor Service, and I was astonished that back in the day, their neonatal mortality rates and maternal mortality rates were better than the United States. And, they were dealing with remote populations and catering to them by, a doctor flying in once a week and scanning everyone, basically, if, bringing the scanning facilities, the ultrasound scanning facilities to these remote communities. Fascinating. I want to get on to talking about the sort of injuries that you saw in the field from improvised explosive devices, ID. I know precious little about this stuff, and I was reading up about the energy transfer from blasts. These pressure waves travel at tens of thousands of feet per second and impose, in the movies, someone gets blown up and they sort of get up and dust themselves off when they'd probably be reduced to mincemeat. Tell us about some of the trauma that you saw in the field from these new and very brutal developments in the theatre of war.
To improvised explosive device act are not new. They've been used for millennia. It's fundamentally the non-conventional military use of an explosive. But the people who use these devices are not confined to the rules and regulations which we would stick to. So they almost control their improvised explosive device to as much as they can to their benefit. And they've utilized basic principles of blast physics. But if you go back to over 100 years ago, there was a Scottish chemist called Monroe, who, when he was experimenting with explosives, I guess as you could in those days, found that the manufacturer's name was imprinted on the far wall of where his experiment was. And he quickly recognized that by shaping an explosive, you were able to concentrate the blast wave. And although IEDs have been used throughout, the centuries, over the last couple of decades, they've been utilized to devastating effect just by using the Monroe principle. And in Iraq, we were beginning to see utilization of a shaped improvised explosive device. So they were channeling that blast wave into one single column. So whilst a conventional weapon would disperse the energy, and the energy would decrease quite rapidly to the power of 3, in an improvised explosive device that was used in Iraq and Afghanistan, they focused that into a single channel. And by using the Monroe principle, you suddenly had this huge peak of energy in one very small confined area. And as you said, it's 10,000, traveling at 10,000 meters per second, thousands degrees Celsius at pressures that fundamentally not much could survive, be it structures or the human body. Initially, they were using it on, by roadsides, on patrols, and on soft-top vehicles. And then in the end of 2006, they started using it against armored vehicles, and that's when we really started seeing a change in the injury patterns. And actually at that first time it was used on armored vehicles or penetrated armored vehicles, I was the SHO in the field hospital out in Iraq, in the southern Iraq near Basra, and I remember hearing the noise in my bed and thinking, oh, someone slammed the door shut. But within 10, 20 minutes, more activity started happening. I could remember suddenly seeing the quick reaction force helicopter going out and people running across the field hospital. And then my pager went off and we all got called in. And we started seeing this repeatedly. And we were seeing a combination of blast injuries. As you said, that shock wave is huge. Blast injury, ballistic and thermal. And we've started recognizing a pattern. I kept an audit doing that 3-month tour of all the IED injuries. And that Venn diagram of blast, ballistic, and thermal, more and more people within that central space of a Venn diagram than maybe just 1 or 2 injuries. Right. And that's when the research into IEDs and the impact on the human body really began. Yes. And it was just devastating injuries.
Because I was reading, I know you get a lot of lower limb trauma if they're in a vehicle, but also the long-lasting effects on traumatic brain injury from the pressure waves, and I'm even been reading that with repetitive rifle firing, the concussive force is now believed to potentially have a shearing effect similar to in sports injuries, chronic traumatic encephalopathy, the same sort of thing.
So,
Shocking.
so the with regards to the IEDs, the mechanism of injury is fourfold. There's the primary blast wave, which, as you said, is that huge energy blast wave that goes into, through, past the casualty, and that blast wave will have an effect on. Well, we used to think it was just air-containing structures in the body, so ears, lungs, even your viscera. But actually, as we looked into it further in CT and MRI scans, we found that actually, even when there was a change in density between organs, such as the liver and lung, the change in density would cause shear forces across those two interfaces, and that shear force was enough of a force to cause trauma at that interface. The secondary injury is the fragmentation injury. So as the blast wave goes through, it obviously carries either the parts of the explosive itself or parts from the ground, and the fragmentation injury into the human body. The third tertiary type classification, the tertiary type of mechanism injury, is that mass movement of the body. So the blast wave's gone through, and then the body is carried, and as that body either falls or hits something, or indeed something goes into the body, the fractures and the amputations all occur. And then the quaternary is all the other injuries, be it thermal, the gas associated with the explosion. The quinary is, as you say, is the long-term effects. So what are the long-term effects on the endocrine system having such a big shockwave? What's the long-term effect of the brain following a traumatic brain injury like that? And the research into that quinary type is ongoing within the military. They have a longitudinal study into casualties from the Iraq and Afghan period, and it'll be years before the results come out, because they want to follow all the way through.
Just wish this is the one trial where one wishes one had a shortage of clinical subjects rather than too many of them. Yeah, Taff, you shared the story of a patient with me with compartment syndrome diagnosed by your juniors in the accident and emergency, or the ER for our American friends, while you were in theatre for another case. And you were telling me about the decision that ultimately saved the leg. Can you walk us through the clinical elements and the leadership steps and what it illustrates about running a trauma service where time's of the essence? If you're in the theatre and you're operating and you've got your juniors out, on the wards and in the emergency room, how do you balance all of that? And tell us that particular story.
Yeah, I don't know how you do it, Jonathan, but you literally sent me a text message as I de-scrubbed from that case, for a compartment syndrome case.
It's better to be lucky than good, Taff.
Yeah. So the next day in our trauma meeting, I was very quick to stand up and say that the two junior doctors, Amelia and Alex, totally spotted this. It was quite genuinely one of those situations where they made the right call, knowing full well that I was scrubbed and task focused doing something else. And Alex came into the trauma theatre and just said, "We've got a compartment syndrome, boss." And there wasn't that hesitation where sometimes you call a junior and say, "Is it compartment syndrome?" And they, don't know, maybe. Is there a pulse?
Yeah,
it wasn't one of those situations.
Yeah.
And you talk about what are the clinical decision-making processes that happen doing that. Well, at that moment, it was like, well, Alex, I'm doing this case, go for it. Book the case, get it into the trauma theatre, see what else is around, but I need you to run with it, and organise it so that when I have de-scrubbed, we can just transition straight across. And there is a bit of serendipity involved there, insofar as when you're doing one case, you don't know what else is going around the hospital.
Sure.
what are the vascular surgeons up to? What are the general surgeons? What are the pediatric teams up to? But fundamentally, I had to have the trust, that clinical trust with the juniors. And I'm super lucky at the moment that the juniors we have at the Royal London, the Trauma Centre, are brilliant. And I have that trust in them to make that call. So from the leadership position, from the clinical decision-making position, all that's in place. All the leadership and management has happened before the on-call has happened. I'm hoping that the on-call, everything just runs smoothly because everyone knows what their job is and they just got up and do it. So literally, I stepped out from one trauma theatre to the next, and I was lucky that the trauma surgeon was already there, and he gave me the wink. Went, yeah, it's a proper one here, Taff. And the calf was just solid, and 50-year-old chap run over by a bus, and the wheels of the bus literally went over his abdomen and leg.
Jesus.
Made the call, and it was one of those brilliant compartment syndrome decompressions where after you do decompression, you can see the contusion, the bruising, that muscular bruising within those compartments. And as you release it, within minutes of releasing it, you saw everything come back, and it was like, we got this. We literally got it.
Your point about leadership, though, I was reflecting back to my training and the day that I called the boss in because I had a guy with a ruptured abdominal aortic aneurysm, and the boss, who was a very serene guy, I was scrubbing. He came in and he didn't scrub. And he said, I'm just going to take a seat. It was a long drive to get here. And I was like, well, aren't you going to do it? He says, no, this is your case. And I said to him afterwards, why did you let me do it? So, it's a big case. He said, there's got to be a first time. But what he did was he gave me, I was obviously nervous, but he gave me the confidence to do what I'd been trained to do. And I think leadership, I don't know today that it's widely taught, but I think there are lessons that we can learn from the business world in medicine about how what's the old expression? Don't get a dog and get surprised when it barks. We have to teach dogs how to bark. We have to give them the reins to do it without obviously being irresponsible. But that's a big call.
Yeah, so I remember exactly a moment in my senior part of my training where it was for my stage of training, really serious case, and the boss went, off you go. And I remember turning to the scrub nurse going, I've not done this before. And she just looked at me and went, well, I know Mr. So-and-so, he wouldn't let you do that if he didn't trust you.
Yeah.
But equally, he's in the coffee room.
Yeah.
So it's, and every trainee in every environment, everything will be different. And don't forget, in an MTC, in an MTC, major trauma center, we are consult delivered service, not so. Yeah. The trainees do get frustrated here, but at the same time, it's a badge of honor when we've brought on a trainee, trust them, and we stand in the wings and let them run.
Get on with it.
Yeah.
So, given your experience managing polytrauma in both conflict zones and the UK Trauma Centre and also in other parts of the world, do you have like a step-by-step approach? You've described a case that was, if you will, barn door of a compartment syndrome, but do you have a step-by-step approach to diagnosing it? And what do you think about this new tool of continuous pressure monitoring and where it fits into the algorithm for you?
Yeah, so my algorithm for compartment syndrome is there's three types of compartment syndrome. There's the no, it's not. Okay, everyone can go to bed. Everyone, it's not compartment syndrome. And then there's like this case. Yes, it is. This is compartment syndrome. We need to do something now. And then there's this grey area, and the grey area is probably a lot broader. Well, it is broader than the yes and no categories. Sure. And that's the ones where, as go back to the previous trainee who would go, "Oh, I'm not sure. Is it? Not sure. Well, what do we do?" Well, of course, we've all learned the 5 Ps. That's super important for them to know right from the outset. So you've got to know the signs and symptoms. The next step that I try and teach the juniors, well, you know the 5 Ps: the pain, the pallor, the paresthesia, pulselessness, paralysis. But why do you develop those signs and symptoms, and where do they come in the time sequence once the compartment starts building up? So that very early on, the first thing it shuts down is the compressible blood vessels, the veins, and so that's where you get the pressure, the hard calf, which you just solid. You pump up anyone's muscular compartment with pressure, there's going to be pain. So pain is out of proportion, should be right up there. But you've got to understand why they're developing the symptoms. At the end of the day, though, you and I both know that compartment syndrome is a clinical decision, because that grey area is so big. There's a group of patients where you just go, I don't know. And, you ask, what's my protocol? What's my strategy? There's protocol and strategy is see the patient. You have to go and see the patient. You cannot make a diagnosis of compartment syndrome over the telephone. If you're unsure, you've got to go in. If you're not getting the information you need from your junior or resident on call, you've got to go and see the patient. And there's that philosophy of Gestalt. Gestalt is that holistic approach to anything where the sum of all the equal parts don't equal the answer. Long short of it, it's that gut feeling. It's that clinical acumen. It's that seeing the patient, looking the whites of their eyes and examining the patient. That if there's one lesson I can talk about protocolization of compartment syndrome, it's you've got to see the patient. Right. But you still might be, well, I don't know, right? They've got a pulse, and because fasciotomies can be devastating wounds. There are, if there's muscle ischemia underneath, then there's a risk of it getting infected, and the journey doesn't end when you do fasciotomies. There's often a weeks, potentially sometimes months of wound healing that needs to occur for the fasciotomies to close. And pressure compartment monitoring is where there's an opportunity to try and narrow that middle ground, that grey area. In the old days, it was stick it in, record it, take a measurement, have a think about it. Has it crossed the delta? Not sure. Go back in now, do it again. In fact, a huge mentor of mine called Nigel Rosto, who's a trauma surgeon in Basingstoke. I remember ringing him up one night. I think it's a compartment syndrome. He said, you think? Or it is? I said, well, I think. He said, what are you going to do? I said, well, I don't know. And he said, well, it's not diagnostic, but you need to add more layers of information. Go and do a pressure study. So I did a pressure study. And of course, I was there at 10 o'clock and where does it go? Which compartment? Is the needle in the right place? Is it at 45 degrees? Have I primed it correctly? All these sort of things go into your mind. And then I rang him up an hour later. And I said, yeah, boss, it's 25. Okay, now do it every hour for the rest of your night.
Yeah.
Okay, and which is the right answer?
Yeah, of course.
Because in that grey area where you still haven't crossed that threshold where you think you're going to go into fasciotomies, you want to know the trend, don't you? Yeah. You want to know where that clinical picture is going and catch it before you've gone past the irreversible damage, the 2, 4, 6. You want to ideally get it in 2, but definitely before the 4. Once you go over 4 hours, then you're going into the irreversible damage zone.
But you're also avoiding doing the unnecessary fasciotomies that you've taught. It's bad enough getting a complication. I used to say, in colorectal work, someone gave someone antibiotics to treat a urinary tract infection, and they then go and get pseudomembranous colitis. That's deeply unfortunate. But if they didn't need the antibiotics in the first place because it wasn't a UTI, that's really difficult to stomach. So it's giving you, and I guess the other thing in a teaching environment, if you've got multiple residents, multiple trainees, and you're saying, do me a favor, go and check this patient out. And it's a different person. These aren't hard objective criteria. I broke my leg, and I've told other guests we've had on this podcast. I remember the resident coming around to me and saying, how's the pain? And I was having this fantasy of punching him the next time he asked me, because it bloody hurt. And I couldn't define whether the pain was getting better or worse. It hurt. I was in pain. You know, news alert, broken bones hurt.
Yeah.
So, yeah. But anyway, so as clinical director, Taff, you've managed everything from complex open fractures, upper limb constructions. I know you like the elbows. We were talking about that often simultaneously. How do you systematize or protocolize that keep both standardized and adaptable when you've got so many moving pieces? I mean, I did my orthopedics obviously many years ago, and so much has changed in your specialty.
Yeah, I did. So in modern day medicine, we wouldn't survive, work, function without MDTs, multidisciplinary team. And the workhorse of the orthopedic department, and I'm sure many other departments, is the morning meeting where the whole department turns up. And it's really important to make sure you've got the right people in the room for that MDT. So it's not just for doctors at that stage. You're also talking about all the subspecialties. It's not just the subspecialties within orthopedics need to be there, be it pelvic and acetabular, lower limb recon, foot and ankle, hand, wrist, shoulder. You also need the trauma coordinators. You also need the junior doctors who have seen the patients in the casualty department to have all the information to hand. And the ideal world, the anaesthetists as well, but quite often the anaesthetists are actually running around, actually trying to get their information and patients prepared. But it's having that MDT structure available on a daily basis and the ability to remain flexible. So we have at the Royal London, we've got a great team of trauma and orthopaedic coordinators who will constantly keep the trauma list up to date throughout the day. It's being dynamic. It's having the communication with the surgeons in theatre or clinic, or the on-call teams and the anaesthetic teams to make sure that that things will change and the priorities continue. So, long short of it, you've got to have a functional and communicative MDT.
Right.
That's key.
It certainly played a huge role in my specialty, absolutely. So going back to the military environment, it often requires improvisation, and you've talked about resource constraint, and you're under extreme pressure. I mean, I know people might be shouting at you at bars, but I doubt anyone's trying to shoot at you. Whereas when you're in the, well, I don't know, maybe literally rather than metaphorically. Can you think of any examples from your army experience that still influence how you triage or operate in the civilian major trauma setting today?
So, with regards to the triage, there's people better than me to have studied triage, and there's transfer a lot of the triage process from the military environment to civilian environment in recent years. There's now people doing PhDs on the statistics and the sensitivity and specificity of triage categories, and they're constantly evolving. Probably not the best person to triage, but from an adaptive and clinical approach and leadership point of view, the thing that I've learned the most from my military career and over the last 2 or 3 years transitioning into the NHS is in my leadership style. And then I'm not just talking about the formal leadership jobs. I'm not just talking the clinical directorship. Every doctor is a leader because you have to lead your team. You have to manage your team and lead your team. And if there's one thing I've learned throughout my military career is that there isn't one particular style of leadership approach. I've been to leadership courses and leadership seminars, and they find out what type of leader you are. Personally, I think the good managers and good leaders have to be completely adaptive and have a very flexible or fluent leadership style. It's knowing when to apply that as well. I'm not going to pretend I'm the best leader in the world. And sure, as I've transitioned from the military to the civilian world, I've got things wrong with my leadership approaches and styles. But it's having the humility and understanding that you can still adapt and change and be fluent. Everyone when I started as a clinical director at Royal London, I became CD 4 months after leaving the army. Everyone was expecting an authoritarian leader. In fact, I think I regret it now, but I think on the first day I took over, there was a few jokes going about on the WhatsApp group, and I said, right, I expect everyone to be at the morning meeting with their shoes polished. I've got uniforms to hand out. I know, obviously, everyone laughed, but then in hindsight, then I probably fed into the.
Well, you could have milked that. You could have milked that for a long time. Actually, I have collaborated with military trained surgeons on a number of projects, and I've found them to actually, to a T, to be more thoughtful and more pensive, shall we say, than their non-military colleagues. In fact, I have a couple of. I've had the privilege of knowing a number of people who've been in the astronaut corps at NASA, and they are the most supreme team players on the face of the earth. And many of them, in fact, struggle. In fact, a couple of doctors struggle in the civilian environment because it's not as structured, and they struggle with how fluid things are. So I'd like to come back. You were talking about the elbows earlier, and you do a lot of complex upper limb peripheral nerve injuries. Can you think of any cases where timing, the nature of the diagnosis, you've talked about early mobilization for elbows, so I've certainly learned something. Thank you. Cases where timing, diagnosis, surgical technique have impacted patients' long-term function, and the sort of things that tickle your fancy.
Yeah, the thing that I wouldn't say tickle my fancies, but something I'm constantly and repeatedly saying to the trainees is when it comes to nerve injuries, time is of the essence. But it's all relative as well. Obviously, if you're dealing with a transection of a nerve, time is of the essence. The sooner you repair that nerve, the better the outcome. You can't argue with that. And there are loads of factors which contribute to the outcome: age, comorbidities, nature of trauma, caliber and type of nerve injured. Is it motor? Is it sensory? But with that sort of transection, trauma to the nerve, time genuinely is of the essence. With regards to other types of nerve injury, and as I said, it's all relative, the type of nerve injury and how that injury nerve occurred. A lot of the nerve injuries I see outside that trauma environment are where there's that post-operative numbness or loss of motor sensation. So Taff, can you have a look at this patient? They've got a bit of numbness in the median nerve after their distal radius fixation. And when did it happen? Well, it happened 3-4 months ago. Well, actually, it's you've got to keep your nerve injuries under close surveillance, because the sooner you address it, even if it's non-operative or operative strategies, the better. We're all going to get patients who have nerve injuries following surgery. It is a recognized complication. It doesn't mean you can be a bull in a china shop, when approaching the nerve, but you have to examine and follow your patients up. You've got to keep on surveillance. Here at Royal London, we have we try we've got new rotation of junior doctors next week, but we try and eliminate them writing NVI in the clinic notes, neurovascular intact. It doesn't mean anything. Neurovascular intact to me means they've asked the patient to wiggle their fingers and they've looked and they've pressed the nails. Okay. But actually, to do a worthwhile, meaningful neurovascular examination in the hand, for instance, You need to check the radial artery. You need to check the ulnar artery. You need to check the median nerve, radial nerve, and ulnar nerve as an absolute minimum. It doesn't take much longer than just asking the patient to wiggle the fingers, and then you have to document that. If you don't have that documentation at the outset, you can't document it after the operation. No, you can't document it down the line. So you've got to keep your nerve injuries under surveillance, because if they're not recovering and you don't intervene in a timely fashion, they're going to end up with a long road of recovery. And ironically, it's the smallest nerve that causes most amount of pain. So in my field, the superficial branch of the radial nerve, if it gets injured or irritated, it is potentially devastating to a patient, but it is arguably one of the smallest nerves in the upper limb, but it's so sensitive, and you have to keep an eye on them and intervene if it's not recovering.
To go back to your point about MVI, any junior who might listen in, or any surgeon listening who had the misfortune of being trained by me, would know that I railed against any abbreviation. NAD stands for no abnormality detected. It also stands for not actually done. I'm not a fan of abbreviations, because I think it breeds a mindset of speed rather than accuracy.
Thoroughness, yeah.
It's a very good, and I presume it's a standard part of follow-up of these patients to make sure that there isn't any evidence of nerve damage down the line.
Yeah, just the point you made there, it's from a medical legal point of view, it's indefensible, because it doesn't mean anything. It doesn't mean you have thought about it as a clinician.
And looked for it. And I guess going back to the compartment syndrome conversation, someone I was talking to was saying that he felt that it was actually missed quite a lot, and that if you look for it in patients, you will see the claw toes. You'll see the patient who had a muscle injury, a vascular injury, and it wasn't picked up, and there is some damage. And I've been questioning how well documented is the incidence of this. And, but equally, as you pointed out, having a fasciotomy, because there may be some compromise to the musculature, the vasculature, the nerves. If you start fasciotomizing everybody, you're going to have a lot of consequences, a lot of negative. I've also wondered about the impact on the mechanics of the leg. If you do a fasciotomy, what does it do to the ability of the muscles? I think I have some chronic exertional compartment syndrome. I'm not letting an orthopod anywhere near my leg, but I think I do, because I do long distance hikes, and I get very achy legs and have to stop and put my leg up in the air, and then it gets better. But what are your thoughts about, are a lot going missed because they're not being looked for? Even minor ones, a small amount of damage down the line.
Yeah, so there's definitely that group of people with compartment syndrome, mostly the delayed diagnosis, where actually you're right, you're in that clinical quandary, should you fasciotomize or not? I think within the foot, there's some very clear, significant complications of performing fasciotomies, particularly if they're even missed very acutely. Because if you open up a compartment with dead muscle, you're in a hiding to nothing, and you're already heading into a situation where that muscle will fibrose. But equally, dead muscle, there's nothing more that bugs love is dead muscle.
Yeah.
But even the fasciotomy is caught early, if you invade any compartment, be it distal radius for wrist fracture or fasciotomy in the lower limb for compartment syndrome, you're going to create healing with fibrosis between all the planes that you have dissected. That's unavoidable. And so you do fasciotomies, knowing full well that there will be some clinical consequences, but the alternative is devastating. So fasciotomies doing a fasciotomy is a brutal is a strong word, but it's long incisions, big compartments. It's not for the faint-hearted.
No, a lot of time in hospital. I'd like to go back to the austere environment conversation, high resource trauma centers that you've worked in. And what qualities or mindsets do you think the next generation of trauma surgeons need to deliver, both speed and precision and care, and also dealing with, when I went to America, having trained in Britain, and my first night on call, and I saw a gentleman who'd been shot with a rather high-powered weapon. That I'd only seen, I think, 2 or 3 gunshot wounds through my entire medical school and training in Britain. And it was, there were a couple of air pistols, a couple of shotguns. One guy who came in had committed suicide. I don't know why they brought him to us. He needed to go somewhere else. And a guy had been shot in the gluteus with a 2.2. But, seeing a guy being shot in the abdomen with a high-powered weapon and done an awful lot of damage. Tell us about the next generation of trauma surgeons. What are they going to look like? What are they going to be dealing with?
Yeah, so I think it depends where they're working. The benefits of ATLS are well documented. If you look at how ATLS all started, I think we have to make sure we, in that sort of environment where you're dealing with high energy trauma, having that protocolized C, A, B, C, D, E. I think we, despite all the other questions you asked, that we have to remember that there are certain environments which have to be protocolized, standardized, so everyone gets the best possible care. So I'm hoping that the trainees of the future will continue to benefit from having those types of courses available and are not only asked to do it, but told to do it. I hope there'll be certain courses such as ATLS which will maintain a part of the curriculum, mandatory part of the curriculum. The biggest, it goes back to the fact you'd only seen a couple of gunshot wounds limited at that. The biggest problem we have in specialization, I think within the UK, I can't speak for around the world, is this balance between generalization and super specialization. When I became a consultant, there was that understanding that on day one of a consultant, I was on the specialist register on the generalistic trauma orthopedics. However, we are getting a lot narrower in our education and specialization. And there's so much knowledge and techniques and equipment out there that we are slowly being forced into being super specialized ourselves. I'm definitely getting to a point now where when I'm on call, I'm thinking, can I take on a Sackier fracture? The answer is no, probably now. And I'd have to transfer that over to my specialist on the, unless there is a life and limb threatening injury. But we still need that basic level of teaching for our juniors coming through. Otherwise, they will not have any strategies whatsoever to deal with anything other than what they have been taught and exposed to. From a broader perspective, whenever I'm asked to talk about this topic with juniors, I'm really quick to tell them that they need to find their own strategies of resilience and coping with vulnerabilities. And that if they're, within their training, you have to be secure in the knowledge that you've got sufficient information and training behind you to take on things which may be out of your comfort zone, but safely. You also have to be surrounded by mates. It's not infrequent that I ring up colleagues and go, "Oh, I don't know about this. What should I do?"
Yeah. No, being humble and asking for help. It's because otherwise it's an awfully lonely place.
Yeah.
Now, beyond the topics that we've discussed, AI everywhere, advanced imaging, got biomaterials up the yin yang in trauma care. I've certainly been following those discussions about PRP and all these interesting stem cells. Which innovations do you think are most going to change the environment for the treatment of polytrauma patients in the next few years, and why?
I think without a shadow of a doubt, we have to harness artificial intelligence. We have to be involved in the discussion. We have to be involved in the planning and development. I'll put my hand out there now. I'm a user of AI. I'm not a developer, but I look at the use of AI with my two hats on, my clinical hat and my management hat. In fact, just this week, we are beginning the process of being one of the first units in the department, in the country rather, to use artificial intelligence in our clinical setting based on the platform we used. So we're part of one of the first UK trials for this particular platform we use. And from a clinical perspective, the thing that I'm most keen on trying to harness for my clinicians is time management, trying to improve their time management or ability to manage their time in the clinic so they can spend more time with the patients and less time doing all the tasks associated with seeing those patients, being writing clinic letters, putting requests in, etc., etc. There's another big arm of diagnostics which I haven't had I don't have any access to, but rapid diagnostic tests with artificial intelligence is clearly where we're going to benefit, particularly in the trauma setting.
Yeah.
The use of this trauma CT-gram is now well established, and most major trauma centres now have very early and easy access to a CT scan.
Right.
But you're still reliant upon the on-call radiologist going through all the images, which is time-consuming. And when you're dealing with polytrauma, time is of the essence to a degree. And if there's any way we can use AI to harness that diagnostic capabilities, then that will only improve the trauma outcomes.
It strikes me that the first and obvious use case that I think is probably going to give a lot of bang for the buck, if you will, is getting rid of the administrivia. Because to my mind, digital medical records have actually impaired clinical functionality, and watching residents spend all their time entering notes instead of looking at a patient, putting hands on, and actually interacting with them is a sad loss.
Yeah, the platform we're beginning to trial will involve of a passive microphone doing a consultation,
right,
which records the entire consultation. There's a bit of learning there. You have to be, anyone who's used these platforms, you have to be vocal in your examination.
Yes,
I am now examining the knee joint. It is flexing from 0 to 90 degrees, but you learn, and by the time you walk to your computer at your desk, it should have populated. Yeah,
fantastic.
And that'll save a huge amount of tasks.
Well, unfortunately, that's all we've got time for today. And I'm kind of sad because I'm fascinated. I've got 100 questions I'd love to ask you. I was just at a military conference seeing all sorts of new and nasty weapon systems that are doubtless going to end up giving you and your colleagues work. I'm very grateful for the work that you do, and it's not trite, but thank you for your service. It's much appreciated by those of us who didn't. And thank you for your wisdom and for imparting it to us today. So again, Taff Edwards, delight having you here.
Absolute pleasure, Jonathan. Thank you very much.
And to the audience listening in, thanks for taking time out of your busy day. Mr. Edwards took time at the end of a busy trauma day to talk to us. So I hope you've enjoyed this. Please tune in for another episode. Share it with your colleagues. Talk about it on social media. You know the drill. And again, if you want to write to us, it's underpressure@nextsense.com, underpressure@nextsens.com. Thanks also to My One for sponsoring and supporting this podcast. And all that remains is for me, your host, Jonathan Sackier, to say thank you, stay safe, stay well, stay curious. Bye for now.